we need to start because we're on a time with this system here. Anyway, does anybody have questions regarding the content that's been covered the last 2 weeks? Hello?
No, I don't.
Okay. Vanessa, you had an issue with the PowerPoint not being accessible?
Yeah, only a few of them, like the arts PowerPoint and some other ones from the gas exchange concept I wasn't able to open, but I mean, it's okay if I can, I guess.
No. I have to double check and make sure what the issue is. So once we get that resolved, I'll send an announcement. Was that the only issue with that?
Yeah.
Okay. And I don't think the other person you were telling me, right, Tanya, is online?
No, it was just Vanessa that was having a hard time with it. And I was going to ask if anyone else was having any difficulties being able to open the PowerPoints.
Okay. Okay. To start off, this is the first time we're doing this, and so it's real important that you come with questions and to seek clarification on anything. And I know that I'm preaching to the choir because you're here, but I am taping it, so I want to make sure that it's on record. Also, for those that don't attend, I hope that they're reviewing the session because then we get clarification in terms of like capstone. I know there's some confusion with the capstone. Some of you have started it, and we have to check with the ATI individuals because there was a miscommunication. So we'll give y'all further notice on that. Otherwise, I think that was the only update we have. So just keep checking your announcements.
Okay.
Is that okay? Okay, so nobody has any questions?
Okay, so if nobody has questions, then that means that we get to leave and go to Starbucks and just drink a bunch of coffee, right?
Yes.
Negative on that. Chad here. Can y'all hear me?
Yes,
Outstanding. I really didn't have any questions on the syllabus or anything, but I did catch on the announcements noted on the 21st that the discussion is now, due yesterday before midnight. Is there going to be any type of leeway on that considering the short announcement?
No, because your calendar actually had it marked for Monday, and because it was opened on Monday morning to give you enough time, we gave you an additional day because those responses are actually what your peers respond to. So that's the only way that we can get y'all enough adequate time to digest the information. Does that make sense?
Yes,
so
ma'am.
We did give you 24. And that's another issue we're facing actually here at school. There's no take-backs. There's no undos. Assignments are there. If you choose not to do them, that's the repercussion of your actions. We're not going to go back at the end of the semester and start looking and reviewing information to give credit. It is what it is. We've already given you the expectation, and I think we're very open with questions. So if you have a question, let us know, and then we can kind of address it. Because I did get an email on Monday asking they had just gotten, or was it Monday morning, like at 9, that they had just gotten access to the discussion board, and so that's why I extended it for the initial post. Okay?
Roger
So-
that, man.
Okay, so how do y'all feel about blood gases? Okay. Well,
This is the point where you guys are supposed to talk.
okay, so you're talking about gas exchange, and we had the concept of gas exchange, not gas exchange, the exemplars of arterial blood gases and RDS and pulmonary embolism. What relationship can you see with that, those concepts? Do you see any relationship? Have y'all read?
Sorry.
Can you hear me, Dr. Rodriguez?
Yes.
With the ABGs, the respiratory alkalosis and acidosis with the gas exchange, that as far as that relates to the ABGs and acid and alkalosis, is that what you're asking?
Right. Yes. So you see respiratory alkalosis and respiratory acidosis with the conditions RDS and pulmonary embolism. And so that's one relationship that we see. And so how do we correct, or when do we see the alkalosis and when do we see the acidosis?
Like just in ARD specifically, or just in general?
In
Like
general, ARDS or pulmonary embolism. What do you remember reading?
Well, I think, well, I don't know, correct me if I'm wrong, but with ARDS, I think the person's going to have a lot of dyspnea, so they're not able to breathe effectively, and I think that leads to hypoxemia, which would be acidotic. Oh no, that would be alkalotic because they're blowing off CO2, right?
Right. They're alkalotic initially because they're short of breath, right?
Yeah.
So their body's compensating and breathing more faster and harder, right, to compensate.
Yeah.
But eventually, yes, it does turn into acidosis. And if you remember reading, correct me if I'm wrong, but pulmonary embolism, you see the initial what? Shortness of breath, right?
Mm-hmm.
And then they start breathing fast. And then if you get a gas, they're in respiratory alkalosis. But if a patient's status changes and it's not detected that they have a pulmonary embolism and get treatment, what can eventually happen?
Well, they'll become acidotic.
They'll become acidotic, and then it can turn into what?
And then I can turn into ARDS.
ARDS, yes.
Yay!
It's all closely related, yes. It's all closely related. So how can we prevent a pulmonary embolism? How could we avoid them going into ARDS? Because we don't want patients to go into ARDS, because then that means what? What's the treatment for ARDS?
Mechanical ventilation.
Mechanical ventilation. And so why can't we do that? It's a machine. It's giving them a break. Why is that such a big deal, and why are we trying to avoid it?
Because they have to get intubated, and then that kind of gives them a higher risk for infection, and all of a sudden, like they're going to be bedbound.
Correct. So we want to prevent it because of the increased risk of infection. So Chad, what measures are we going to do to help prevent pulmonary embolism in our practice? Because Vanessa's already said that we don't want to ventilate the patient. We don't want to put them on a ventilator because it'll increase the likelihood of their infection. But what can we do to prevent a pulmonary embolism to occur, knowing that it ends up creating an issue for ours. Chad?
Well, ma'am, right now my brain's kind of still stuck on that whole canvas issue with the schedule conflict going on. So I'm trying to absorb what I can through this conversation, but in regards to contributing, I'm not going to be much use for y'all.
Okay.
Is it going to
Okay.
be like to help Chad? I'm going to say like early ambulation to prevent blood clots.
Early ambulation to prevent blood clots. Okay.
Or like
What else do you do?
thrombolytic therapy.
The medications.
What types of
Medication?
medications?
What is it, like heparin, Lovenox?
What do we
Lovenox?
do? What do we do before we give medications?
Check blood levels. No.
No, I mean, what intervention could we put in place prior to having to give the patient a shot every day?
Like spirometry?
Spirometry is going to help with gas exchange, but it's not going to help with perfusion and preventing a clot. So what can we do that will prevent that?
Compression stockings.
Yeah.
Exactly. Now, if the doctor orders compression stockings and they are laying over on the nightstand, does that help?
No.
No.
Compression stockings and SCDs are one of the big things that are ignored in regards to doctors' orders. Nurses put them in the room, but they don't necessarily put them on the patient.
Okay. So suppose that if you were triaging a patient with a pulmonary embolism, what would you see clinically? What kind of picture would you see?
Like short of breath, chest pain, anxiety.
Short of breath, chest pain. And so what's happening with that?
There's
Like,
an
why is
obstruction.
it,
So
the what?
sorry.
Go ahead, Vanessa.
Saying there's an obstruction somewhere in the lungs, so that's making it difficult for them to breathe.
Right. Okay. And so what are we going to do? What's the immediate response for treatment of a pulmonary embolism?
O2?
Okay. So we're giving O2. Is the O2 going to help move the clot?
No.
No.
Okay. So we're giving O2 because
I would think just to supplement, it's just until you get some other stuff like chest x-ray and ABGs and all that stuff. No?
Okay, so we're just helping them because, again, they're short of breath, they're having trouble breathing, right? So we want to just help alleviate and decrease their work of breathing. But ideally, what's the treatment that we'll do to remove a clot? Remember, less invasive. Do you remember reading that, Vanessa or Paul?
No.
I mean, the
I
only
didn't
thing
read it yet.
was the thrombolytic therapy that I saw,
That
but
anticoagulation to break it up, but I mean something less invasive than that. Is that what
Yes,
you're asking? Less invasive?
the clot buster, right? The clot buster will help. The TPA will help break up that clot so that it's not an issue anymore, and it's not occluding that pulmonary artery or the bronchial.
I'm sorry,
Does that
what
make
was
sense?
that? TPA? Is that what you
TPA.
Oh,
Tissue plasminogenic activator.
okay.
Okay? And so, Vanessa, this patient, that if you were taking care of a patient with a pulmonary embolism, what other care measures do you think are important for them? Because it's just a clot. Like, is there, you know, like once we do the clot buster, is there anything that you would want to include in your plan of care for this patient? Because it seems fairly easy, no? Or are these is this a potentially dangerous patient that could turn into more complications?
Oh, I think there would be a risk for them to develop something more serious. So I would say yes, that it's pretty dangerous. So I would say maybe like keeping them on bed rest and checking vitals and just provide teaching on what they need to look for. If there's any kind of signs and symptoms of getting worse, like if the thrombus actually moves or actually causes something more serious.
What system of the body will be affected with that? What, if, aside from making sure that they get bed rest and giving them that medication, how are we going to know that their respiratory or their cardiovascular system is not compromised? It's something basic.
They're going to be breathing normally?
You're going to be assessing respiratory status. You're going to be assessing vital signs, right? Checking vital signs. Is it likely that the patient might suffer hypotension with a pulmonary embolism?
Hypotension.
Hypotension.
I'm not sure. I mean, I don't know why they would develop hypotension. Would it be because their circulation is going to be affected?
Their circulation not necessarily won't be affected, but remember respiratory, if somebody's acidotic or somebody that's alkalotic, those stress, it makes the heart compensate. And so if the patient is having difficulty breathing and is not on continuous IV fluids and things like that, they can end up eventually requiring like vasopressors and things like that. Does that make sense?
Okay, yeah.
So looking at the bigger picture, these are patients that can become very critically ill. So you'll need to be monitoring a lot other than just giving the TPA. Does that make sense? Tanya, you have anything to add? Looks like you wanted to say something.
Not on that part. I'm good.
Okay. Okay, so what about if we were taking care of a patient that had a pulmonary embolism and we were concerned with respiratory distress syndrome, what are you going to see on a ABG? Was I clear on my question? Because sometimes I don't.
Can you kind of clarify that? I wasn't, like if they are having respiratory distress syndrome?
Yes, like if we suspect that they're going into respiratory distress, what are we going to see on an ABG?
Initially for the alkalosis or for the acidosis?
Okay, so when you say alkalosis, can you give me an ABG that's alkalotic?
Well, the pH is going to go high. It's going to be above 7.45. The CO2 is going to, the CO2 is going to
be low.
It's going to be low because they can't blow it off because they're having the pain and they're deep breathing. They're going to be shallow breathing, so they can't blow it off. So the CO2 is going to, was it going to increase?
CO2 will decrease, or it'll be, yeah.
So your respiratory, you said your pH will be above 7.45, and then your CO2 will be what? High or low? Low, right?
Yeah.
So when you think about alkalosis, think of the laboring mom that she's like breathing hard and she's contracting and she's in a lot of stress. So she's not retaining the CO2, right?
Mm-hmm.
So that's the classic example of respiratory alkalosis. So thinking back of pulmonary embolism, the first thing that Vanessa said was they have shortness of breath, they have difficulty breathing, the dyspnea, right? So it's very typical for you to see the alkalosis because they're trying to compensate for the inability to breathe, so they're breathing harder and faster, okay? So then what's going to happen if they do this for a long time? Eventually, what's the body going to do? Or what's going to happen to the patient?
Gonna get fatigued.
It's going to get into what?
Acidosis.
Acidosis. So tell me what acidosis looks like on your arterial blood gases.
Below the 7.35, less than 7.35.
Less than 7.35. And then?
Well, the O2 is going to drop,
Okay.
and then it's going to be
And then your CO2 is going to be
up.
up. Right. And it's going to be up because we have too much CO2. So in level 1, you should have learned that acidosis, a classic example would be a patient that received too much morphine overdose. It's because they're not breathing enough to get rid of the excess CO2. Okay? So because, let's just say this patient ended up going into respiratory acidosis, what treatments are we looking at for this patient?
Like bronchodilators or hydration, O2.
Okay, bronchodilators. What do bronchodilators do? Actually,
Open up.
let's not talk about that. Let's say, okay, what does respiratory distress syndrome mean? What is happening to the lungs?
They're not moving. They're not working right.
They're not working right. Tanya, it looks like you're dying to say something.
No, there's something that I'm waiting for, like the right moment to insert this. When you guys are talking about the ABGs and you say that the pH is high and the CO2 is low, what is the bicarb? Is it high, normal, or low?
In acidosis, it'll go up, right?
No, with the alkalosis, when the patient is first going into acute respiratory distress, or with the PE, what are you going to see with the bicarb? What is it going to be?
The bicarbs are gonna decrease, no?
Initially, remember, it's probably going to be normal. Your body hasn't compensated yet.
Okay.
And
Yeah, because
then
that's one.
and then as you're going towards, then you're going to start to compensate, and your bicarb, is it going to go high or low?
Low.
Isn't it going to go high?
Oh,
Isn't the
high.
bicarb going to go high
Yeah,
to compensate for the acidosis?
Yeah.
The bicarb is going to go,
It'll go up because it'll start compensating.
yes. Now, what
Your
is
kidneys start producing the bicarbs.
yes, what is your PO2 going to be
Initially,
Your oxygen.
initially?
I think initially it'll go down and then it'll start to increase.
Okay, why is it going to go down?
Because the body's not getting enough oxygenation. The circulation is not.
And why aren't they getting enough oxygenation?
Because they are
Because you have that
dry.
blockage. You have the shallow breathing.
Exactly, so that's what you have to remember, because with the PE, there is a blockage. So it doesn't necessarily matter how much you breathe in when there's a blockage, and you're not able to create that gas exchange, then your O2 is going to be going down because the oxygen you breathe in is not being dispersed through the body. Make sense?
Yes.
Yes.
Okay, that's all I was going to say.
Okay. So review y'all's bicarbonate, where it comes from, the kidneys. What bicarbonate is acid, pretty much. And so anytime we're lacking acid, the kidneys are going to stop getting rid of it. They're going to hold on to it. If they have too much acid, they're going to get rid of the bicarbonate. They're not going to reabsorb it. And I just got a notification we have 10 minutes on our meeting. So, is this helpful, or how are you getting it, or no?
No, it's
Yeah,
helpful to discuss it and get everybody's, input and everybody's different ideas, and then y'all kind of straighten it out and kind of realign it.
Oh, Carolyn's on here. Carolyn hasn't said.
Yeah, Carolyn's been quiet the whole time.
I've been trying to say something, but I think my voice is low.
No, I can hear you.
Now we hear you.
All right, I'm here.
Okay. Okay.
So, guys, what type of patient is at risk for developing a PE?
After surgery,
Okay, keep going.
Patients with clotting disorders or patients with low activity going on, your bed rested immobile patients or your lazy patients.
Nice to hear from you, Chad.
Sorry about that, ma'am. Started off on a bit of a sour note, but I'm trying to get my head back in the game.
Well, I'm glad you are. Who else is at a really high risk of developing PE? Dr. Rodriguez, we're going to have to get that Jeopardy tune so that when we ask questions and it's silent, we can just play that.
Yeah. And I think, honestly, who has read this content? I know Vanessa has, because she's answering good questions, and Paul seems to have known. But Carolyn and Chad, did y'all read?
I did.
Yeah. You did?
Yes.
Okay. What about Chad?
No, ma'am, I have not read the material.
Okay. Okay. So,
How about the patients who are taking oral medications for family planning?
birth control. Yes. Good. Good. Anyone on birth control is at high risk of developing a clot.
Especially if they smoke and they're on birth control. That increases the risk even higher.
Is that what you were looking for, Miss Mansell, the smoker?
No, there's also a fat emboli. So when you break a bone, if you have any type of bone fracture, you're running a very high risk of developing a fat emboli that is going to migrate as well. So we need to make sure that we are assessing really, really well whenever we have a patient with a broken bone, because it's not something that you would maybe see immediately, but it's something that we're going to see on the follow-up assessments. So that's one of those things that we have to watch for, because we know it is a possible complication.
Okay, thank you.
Okay, so what we're going to have you do is, I want y'all to review the respiratory distress syndrome, physiology, pathophysiology of it, to be able to explain or to understand why we do the treatments we do to help it. Does that make sense?
Yes.
Yes.
Am I clear?
Mhm.
Yeah. Okay, because I think once you understand that, I think you'll be able to figure out why do we use a ventilator? Why does it end up leading to cardiovascular collapsing and all of that? And so we can talk about that. We'll touch on that next week. And I think next week you have, okay, so you have liver and hepatitis, which, and the TBIs and encephalopathy. So we can look at clarifying any of that content as well.
Okay.
Okay. Did you have any questions? Other questions?
If you have any time, can you please touch base on the ICU procedural pain and comatose? Because when I was reading, I didn't see much about all that.
Oh, the thing with that comfort concept is that anytime somebody is getting a tube in their mouth or getting IV starts or just is feeling crappy, what's going to happen? Do you think their pain is going to be high or low?
High.
Okay, it's going to be very high, right? And so really what your take back from the comfort concept is that physiologically it puts strain on everything and it makes you more sensitive to pain. So biggest thing is if you have somebody on a ventilator, are they going to be able to communicate pain?
No.
No. So what kind of tools would you use for a patient that's nonverbal?
Vital
The
signs.
writing.
Okay, so if I have a tube in my mouth, I have all these lines, do you think I'm going to hold a pen and write this stuff down?
Vital signs.
Okay.
Mine did it yesterday, Dr. Rodriguez.
All right, Paul. Okay. No, they didn't. Well, you can use actually the FLAC scale. The FLAC scale is good because it looks at their tone, it looks at their reaction, if they're grimacing, all of that it'll take into account. But also there's what's called hierarchy of pain measures, which is what Carolyn is talking about. The vital signs, looking at their responses and their facial expressions, their tone. Do you remember reading that, Carolyn?
Yes.
That's important, okay? And then just understanding that their sensitivity to pain is going to be heightened. So we don't want the patient to fight the ventilator while they're sick, but eventually we don't want to encourage them to stay on the ventilator because remember Vanessa said it increases the likelihood of infection. So it's increasing their risk for developing pneumonia. So we don't want them to stay on the vent for too long. So a lot of times they'll refer to what's called a sedation vacation.
Mm-hmm.
Yes, and that's really because they want the patient, once they're improving, and how they improve is based on x-ray. They look at the x-ray and they see, is the RDS recovering? Are there less infiltrates and things like that? And once they see that, then they'll start weaning them off of the sedation.
Okay.
So it all kind of ties together. Do you get it or no?
I did.
Okay, good.
Mhm.
Anything to add, Tanya? Because I don't want them to disconnect us.
Yeah, we're about to be disconnected. Real quick, ICU procedural pain. If we are doing something that we know is going to cause a lot of pain to the patient, pre-medicate. Give them the pain medication before we do whatever it is that is going to be causing them pain. And then you're not going to have quite as bad of a physiological response because the pain is going to be managed. We have less than 1 minute.
Okay. So we're going to let you take that back and digest it, and I think I might, we'll meet next week. If you have questions, we thank you. Chad, whose group are you in? Are you in my class or in Moncel's class?
I'm in your class, ma'am.
Okay, could you call me after this conference?
Yes, ma'am.
Okay. Okay, so if y'all don't have any other questions, you can email us. If not, bring your questions for next week. And we thank you for coming. It's so little of you. We hope that some some other students decide to come next time. Okay?
Thank you.
Okay, thank you.
Thanks. Thanks.
Thank you, ma'am.